Hi everyone, today we're going to be talking about perinatal conditions in Chapter 39. We'll get a little bit of overview here. The neonatal period is a very vulnerable time with many physiological changes that occur as the child transitions from intrauterine to extrauterine life. 2/3 of infant deaths occur in the first 28 days in the U.S. Many health issues can occur during this transition time, so it's important for the primary care provider to feel comfortable with these physiological changes that occur. There are standards of care that have been set forth by Healthy People 2020 to improve maternal health and pregnancy outcomes, and this in turn reduces disabilities in infants. As you are in your clinical rotations, you've heard of likely all of these standards of care, and they include the ones listed on the screen. There are a couple of places to be able to review guidelines for the standards of care in the newborn, and those can include the guidelines for perinatal care from the American Academy of Pediatricians and the ACOG guidelines, and then also there are guidelines for health supervision of infants, children, and adults through Bright Futures. Let's talk a little bit about anatomy and physiology as the infant transitions from intrauterine to extrauterine life. We know why a baby is in utero, that metabolic functions are provided by the placenta. With that change in the high pulmonary vascular pressure, with the cord dropping and this decreasing, this stimulates the infant to breathe, and blood flows to the lungs, and there's the closure of the foramen ovale and the ductus arteriosus. Nutrients are now received through the GI tract. Waste and chemical balance are maintained by the renal system, and the liver begins to excrete toxins. Let's go over a few definitions. High-risk pregnancy are those that are at increased risk for abortion, fetal deaths, prematurity, intrauterine growth retardation, some congenital malformations, intellectual disabilities. With acquired health problems, these can occur due to exposure to poor nutrition, alcohol, drugs, infections, and maternal complications. I meant to say maternal conditions and not maternal complications, excuse me. The next is genetic problems. We know that there is a history of genetic issues, whether they're congenital anomalies, intellectual disabilities, familial diseases, inborn errors of metabolism, that there's increased likelihood that that could occur with the infant. And because many of these conditions are not seen on physical exam, it's important to have a full family history to identify any little ones that may be at a high risk. Perinatal complications are those that occur immediately before or right after birth. These can include both mechanical and anoxic trauma that it can occur to baby during labor and delivery. Predisposing factors for an injury during birth could include prematurity, disproportion between baby's head and mom's pelvis, prolonged labor, presentation. Next, let's talk a little bit about the assessment of the neonate. It's important to get a past health history of mom. You want to know about their obstetrical history, the number of pregnancies, number of infants born alive or stillborn, any elective or spontaneous abortions, preterm and term deliveries, if these were vaginal delivery sections, and then the health status of these babies. You want to know as much information as you can get about the family history. If there's been any genetic conditions, any known birth defects, intellectual disabilities, or any known diseases. You want to delve into the mom's current obstetrical history prior to delivery, you're wanting to know more about depression, any other mental health issues, care during this time for mom, medications that they've been on, any recent infections, use of alcohol, drugs, or use of cigarettes, any exposure to metals, what their blood sugar has been, whether they've had any glucose intolerance, whether there's been any hypertension, and then asking about social history. On physical exam of the baby immediately after birth, you're going to want to know their APGAR scores, their gestational age, vital signs, assessment of the lungs, and umbilical cord. The baby will be stabilized in the delivery room and then will be moved to the nursery for a more complete physical exam. There's an excellent table on page 1089, table 39-2, that gives physical exam systems and the findings for neonates. Please be sure and refer to it. This is also the time when newborn screenings will take place, screenings for HIV and hepatitis as well. As the newborn is transitioning, there will be close observation in the extrauterine time, but initial care is going to include prophylaxis for eye infections and vitamin K injections. This will be the time to begin to establish feedings, and then there'll be a necessary follow-up in 2 to 3 days to ensure that baby is receiving adequate nutrition. There are going to be things that you're going to want to talk with the parents about in preparation for when the discharge occurs, and to educate on physical care. First is going to be umbilical cord care. In the book, it briefly mentions that traditionally it's been thought to apply alcohol to the cord to help it dry and to separate. Some have recommended using a bactericidal or an antimicrobial agent to reduce any colonization of Staph aureus for the healing umbilical cord, but the research shows, and the American Academy of Pediatrics supports doing dry care of the umbilical cord, which is probably what most of you are familiar with. And that's just allowing, tucking the diaper below the umbilical cord and allowing air to dry the umbilical cord out, and it will fall off on its own. You will also be talking with parents about circumcisions of little boys, so it's important to be able to list the pros and the cons of having a circumcision performed. Education will be given on bathing of the infant, any oils or powders that the parents may ask about, and what needs to be used, and then the use of diapers. Early discharge and follow-up is not unexpected in the hospital. What we have to prepare parents for is to be able to identify if there's anything unusual going on at home, so they can reach out to their provider. And this could be issues with breastfeeding, the little one losing weight, jaundice, or dehydration. In the book on box 39-2 on page 1093, there's a good guide for the guidelines for early discharge of normal, healthy newborns. And then on page 1094, there's guidelines for discharge and follow-up for high-risk babies or those with special needs. So please refer to those. Okay, let's get into some common conditions seen with babies. The first thing we're going to talk about are milia, and these are pearly little white papules that can be found on the forehead, the nose, and the cheeks. No treatment is necessary, and they will exfoliate on their own. Moms get worried about them, but just reassure them. Be sure and look at pictures of these conditions, because I think pictures, as the saying goes, are worth more than 1,000 words. You'll be able to identify and feel more comfortable when you see these on little ones. The next we're going to talk about is sebaceous hyperplasia, and these are some yellow-white papules that are seen in the follicles of the nose, the forehead, the lip, and the cheek. These will decrease in size over the first few weeks and disappear quickly. Sorry about that. The next thing we're going to talk about is erythema toxicum. So these are firm yellow-white little papules about 1 to 2 millimeters that are surrounded by an erythemus section. They usually develop in the first 24 to 48 hours. Their cause is unknown, but no treatment is required. And the next is sucking blisters, and these are a result of the baby having a vigorous sucking action while still in the womb. These will resolve on their own. The next is cutis marmorata, and this is a lacy appearance to the skin that is often seen with cooler environmental temperatures. It's a vasomotor response that disappears as the little one gets older. Next is the harlequin color change. And this is where there's a difference in colors from the forehead to the pubis, from a red half and a pale half. And it is a benign condition that is transient and will resolve. Next is our Mongolian spots, cafe au lait spots, salmon patch, port wine stains. There's more about those in chapter 37 of these skin conditions. Next is Nevus sebaceous, and these are little yellow hairless smooth plaques that can be found on the head and the neck. If you took out some of the content and looked at it underneath the slide, these would be an abundance of sebaceous glands. And as the little one gets older and usually going into adolescence, they can almost become wart-like. So it's important that they be evaluated before that occurs. If they remain, and as the individual grows into adulthood, they can be associated with some secondary malignancies related to a basal cell carcinoma. It's recommended that they be excised during adolescence and would require going to a pediatric dermatologist. You may note skin dimplings, and these can be over the over-body prominences, especially in the sacral area. If they're not associated with any concerns such as any congenital rubella, a deletion of the long arm of chromosome 18, then no treatment is needed. The little one can have preauricular sinus tracts and pits. This can be seen on one side or both sides, and they result from imperfect fusion of the tubercles during gestational development, most likely familial and common in females and in African Americans. They can be occasionally associated with other anomalies of the ears and face. Because of this, you want to just assess for normal newborn hearing. Next, amniotic constriction bands. This can occur where there's permanent depression of underlying tissues from a uterofibrous strand when baby was inside mom. It can cause some associated anomalies. If there are concerns for these, they may require plastic surgery. They can be seen with craniofacial anomalies or thoracic or abdominal wall defects. The treatment is dependent on the severity. Little ones can have supernumerary nipples, which can be one or multiple accessory nipples, and sometimes areola occur from the mid-axilla to the inguinal area. The cause is unknown, and usually no treatment is needed. So let's focus a little bit on the head, face, and eye conditions of little ones. So first is caput succidium, which is usually diffuse swelling of the soft tissue in the scalp. It usually crosses the suture lines. It can happen during a traumatic delivery. One of the differential diagnoses that you have to rule out is a hematoma, and no treatment is necessary. It will resolve on its own. A cephalohematoma is a collection of blood under the scalp that does not cross the suture line. This can result from trauma during a difficult delivery, and the swelling can appear hours to days after delivery. The condition typically resolves in a few weeks to months. Depending on the volume of the hematoma, it's important to observe for elevated bilirubin levels as the blood breaks down. The first is craniotabs, and this is thinning of the bone of the scalp. It's a normal variation of the parietal bone and usually seen near the sagittal suture line. It can be seen with prematurity. There's no treatment as these resolve on their own. Regarding congenital cataracts, you can get more information on that on chapter 29 in the eye chapter. Next, let's talk about some respiratory conditions. The first thing we'll talk about is respiratory distress syndrome, and that is usually secondary to a deficiency in the surfactant. We can see it with alveolar atelectasis, which is decreased lung compliance. This is one of the most common pulmonary issues in newborns, and the incident rises rapidly for little ones less than 33 to 34 weeks gestation. Approximately 50% of all neonatal deaths result from RDS or its complications. When assessing for this, it's important to review clinical findings. Did you have a diabetic mom, preterm labor, precipitous, or a C-section delivery? Were there multiple births? Were there any asphyxia noted during the delivery? On physical exam, you may notice some tachypnea. There may be grunting retractions, some duskiness to the skin, cyanosis. There may be normal breath sounds, but there may also be diminished breath sounds. You could have fine rails noted with inspiration. A chest x-ray may be ordered, and there may be some fine reticular granularity noted. Blood gases, their findings may be off, and you may note hypoxemia, hypercapnia. There may be a mix of respiratory and metabolic acidosis. Management will include supportive care and mechanical ventilation as needed for moms that are expected to deliver prematurely. Corticosteroids are given to help accelerate lung development. And then there's the use of exogenous surfactant after delivery. Next, let's talk about transient tachypnea of the newborn, which is a respiratory condition that results from incomplete evacuation of the fetal lung fluid in term infants. So as baby is coming out through a vaginal delivery, that compression on the chest to expel that fluid. It's more common in C-sections, usually disappears within the first 24 to 48 hours. As we talked about, you can have tachypnea, some expiratory grunting and retractions. When you auscultate the lungs, you may not appreciate any differences, and it may respond to minimal oxygen. Diagnostic studies may include a X-ray that shows prominent pulmonary vascular markings, fluid noted along fissure lines, and over-aeration in the X-ray. Management is observation and monitoring. Oxygen if SATS levels should fall, and mechanical vent if mechanical ventilation is rare. The next is a meconium aspiration syndrome, and it's where meconium is mixed with the amniotic fluid. This is typically seen in term and post-term babies. If a baby is in distress during delivery, it can increase intestinal peristalsis and relax the anal sphincter, resulting in that release of meconium. X-ray can show patchy infiltrates, some streaking and flattening of the diaphragm. Management, if the heart rate is greater than 100, they have good respiratory effort, good muscle tone, then intubation is not required. You would lean towards more supportive care and management of the respiratory distress. Intubation and suctioning is only when the infant has a depressed breathing pattern and has a heart rate less than 100 beats per minute. We are going to move on to the GI tract, so let's close out this video and start on the GI tract with the next one. Thank you.